Our really new and exciting cohort of advanced prostate cancer survivors. So Ironman is the International Registry of Men with Advanced Prostate Cancer. And I thought that I would start with my disclosures. And can you see my full screen now?
Yes.
Perfect. Great. And if people are interested in getting regular updates about the Ironman registry, I've put my own individual Twitter account as well as the Ironman studies Twitter feed. And anyone who'd like a copy of my slides are very welcome to it. So first, disclosures. So this is a really exciting collaboration that has formed between several academic institutions, the Movember Foundation, which is a global men's health organization, and then a number of pharmaceutical companies that have done important discovery work in therapies for advanced prostate cancer. In addition, I wanted to make one more disclosure. I serve currently and for the past 7 years on an expert peer review panel for an organization called the Cancer Prevention Research Institute of Texas. I receive an honorarium. They are a large funder of cancer prevention research in Texas. They are funded by the Texas legislature. And as such, I just want to disclose that I strongly oppose the recent Texas Senate Bill SB 8 that was passed by the Texas legislature, which is highly discriminatory against women and I believe will have devastating effects on public health and reproductive rights. So in terms of this talk today, I thought I would first describe what the motivation was for a global registry of men who have advanced prostate cancer. Secondly, to go into some details about the study design, present some preliminary results, and then talk a lot about the lessons we've learned with this registry, and I think will be really relevant to many of you who might be thinking about new global projects as well. So in terms of why would we be interested in a registry of men with advanced prostate cancer, I think to put this in the global context, each year 1.6 million men will be diagnosed with prostate cancer, and it's the leading cause of cancer incidence in men in more than 100 countries around the world. And globally each year, 375,000 men will die of prostate cancer. And this figure here shows you the age-adjusted prostate cancer mortality rates in different countries in 2020. The darker red countries are those with the highest mortality rates from prostate cancer. And what you can see here is there's almost, actually, if you look at the areas with the highest versus the lowest prostate cancer mortality, it's a more than 10-fold difference. And we have some really high rates of mortality from prostate cancer in parts of Southern Africa, the Caribbean countries, men of African ancestry in the United States, and then parts of South America. So there's a huge geographic increase in prostate cancer mortality around the world. In terms of survivorship, and these are data from the United States, an estimate of 2019, in the United States, there were an estimated 3.6 million men who were considered to be prostate cancer survivors. So they could have been diagnosed at any time point and with any stage of disease. And you can see compared to other numbers of cancer survivors among men, prostate cancer is the largest number of men. But this group is actually a very heterogeneous group in terms of their survivorship needs, their likelihood to go on to die of their disease. And so specifically, if we think about men who have more advanced or metastatic forms of prostate cancer, that specific survivorship group, there's actually no population level data, nor is there really for any metastatic cancer survivor. But in a good estimate, at least in the United States, is that currently 180,000 men are living with a metastatic prostate cancer diagnosis. And the reason this is important is that these are the men really who are at the greatest risk of dying of prostate cancer. These are the men also who are going to really suffer the greatest in terms of quality of life, both because of the disease state they have as well as because of the types of treatments they're getting. Yet very little is actually, there's a fair bit of work that's been done to date looking at overall prostate cancer survivorship, especially localized disease, but relatively little so far in this advanced disease state. Another important thing to consider is that the clinical landscape for the treatment of men who have advanced prostate cancer has changed really dramatically. And in the last 4 years alone, there have been 9 therapies that have been newly approved by the FDA. And each of these has a small advantage in terms of survival. However, in the clinical trials that have been done to get FDA approval, there's been sort of a paucity of quality of life data, and little is known really about what the right sequence is for these treatments, or what is the right, are there subgroups of men who may benefit, or in fact might have greater detriments in quality of life as a result of the specific medication or biomarker. And then another key issue that really motivated this study was the significant racial disparities that exist in prostate cancer. You could see that at a global scale, but if we think about just in the United States at a population level, Black men are 76% more likely to be diagnosed with prostate cancer, and they're 120% more likely to die of prostate cancer compared to white men in the United States. And actually, 2 individuals in our group have been delving into the racial disparities in greater detail. Megan Hansen, who is a UMass medical student, and Bailey Veselkiv, who's here at the Harvard School of Public Health, looked within the health professionals follow-up study and said, well, to what extent do differences in lifestyle factors such as smoking or obesity, what about differences in diet, screening practices, diagnostic intensity? If we could make all of the groups similar, do you still see this excess risk of mortality? In fact, for both incidence and mortality, there is this excess for Black men compared to white men. However, despite these well-known racial disparities in prostate cancer, there remains really a lack of diversity in the clinical trials in prostate cancer. So Emily Renksock, who is a MD PhD student here at Harvard, published an assessment of 70 clinical trials in prostate cancer, either treatment trials, prevention, or screening trials. She looked at the reporting of self-reported information on race and ethnicity. One take-home that she saw was that only 62% or 63% of all trials even reported data on race information. And then when you looked at the percent of trials, with information on race, it was quite low. And in fact, actually, when you look at the trials that didn't report in their study about race ethnicity, actually all of the trials, when Emily reached out to the investigators, reported that, well, the reason I didn't report on it was because 100% of the men in the study were white. And so I think this figure really takes home the fact that despite the fact these considerable racial disparities exist and an increasing appreciation that men of different ancestries may respond differently to therapies, there's been a lack of increased enrollment of diverse populations in prostate cancer trials over time. And then finally, I think there's a number of additional questions that we've been aiming to address with this project to provide some real world evidence that could help inform clinical guidelines and practice patterns for men who are advanced prostate cancer survivors. And as I mentioned, what is the real life experience in terms of quality of life and patient reported outcomes? And this has been very inconsistent in clinical trials. So we really don't know how these drugs, or even how things like an individual's lifestyle, so could engaging in physical activity improve the quality of life experience for these individuals. There's been very little, as I said, to date, looking at disparities, both in survival and quality of life among men with advanced disease. And there's a real need for validated prognostic and predictive biomarkers in this diverse population. So these all things kind of taken together were really the motivation for this new study that was not so new now. We initiated in 2017, and we've been working actively in the design of the study, putting together the right stakeholders, identifying the patient populations, and identifying funding as well. And we've been able to enroll, as you'll see in a little bit, close to half of the cohort so far. So this has been a wonderful collaboration, as I mentioned, and myself and two medical oncologists, Phil Kantoff, who was the chair of medicine at Memorial Sloan Kettering, is now at Convergent Therapeutics, and Dan George, who's the head of GU Medical Oncology at Duke Cancer Center. So the three of us were the founding co-principal investigators. And then as part of our executive team, we have Jake Vincent, who heads up the Prostate Cancer Clinical Trials Consortium. They're our partner in making sure the study gets done. And then Paul Valenti, who's the global lead for that Movember Foundation, has been a critical partner in this executive committee as well. Here's the website for Ironman, and just to give you kind of an overview of what the study design looks like. So first, our vision in creating a global registry was to be able to understand patient care, patient experiences, identify and validate biomarkers, and examine a range of different health outcomes for the survivorship experience of men with advanced prostate cancer in a real world setting, in the setting in which men are taking therapies in different sequencings and combinations that they're getting from their clinical team. We're also intending it to help identify what are the unmet needs for this patient population and how can we best improve cancer survivorship for these men. And then finally, one of the overarching principles of this study has been to create a resource for the global cancer and clinical research community. We really want people to be collaborating with this study, to propose projects, to propose use of the registry data. So we really welcome collaborations. Our goal currently is to enroll at least 5,000 men. That's what our current funding is for, in men with advanced prostate cancer. And right now we have partnerships with investigators in 16 countries. These countries you can see here, we have from North America, we have Brazil and South America, we have 3 Caribbean countries, a number of countries in Europe, Africa, and then in Australia. So the green countries are those that are now actively enrolling participants, and then the orange countries are those that are in various stages of startup. We actually just opened enrollment in Nigeria about 4 weeks ago, and we've enrolled already 26 men on the study, which is extremely exciting. And we're getting very close to opening up our Caribbean sites as well. And the selection of these countries really was for a number of reasons. We really wanted, as I mentioned, given the racial disparities that exist in prostate cancer, to enroll a diverse population and really identify what's happening clinically in advanced prostate cancer patients in countries that look clinically very different than what we see in North America. It's also based on existing partnerships and really unique aspects of these study populations. You will see, though, kind of a gaping hole in Asia, and we are hoping sort of in a phase 2 to be able to secure some funding that would allow us to enroll men from different parts throughout Asia. Again, in the United States, this figure here shows you states that have higher versus lower prostate cancer mortality, particularly in the southeast part of the United States. The rates of prostate cancer death are considerably higher than other parts of the country. So we've really set out in particular to have partnerships with cancer centers, urologic practices. We've aimed to really enroll from maybe it's a cancer center that has close connections with community-based enrollment. Our goal has really been to enroll a population that's diverse with respect to socioeconomic status, race, ethnicity, geography, as well as potential access to care. The sites in green, red are already active, and the ones that are sort of shaded white are pending activation. We've also partnered with the Veterans Administration, and which is a very exciting and important collaboration with that we're hoping to start opening and enrolling very soon. So what do we even mean by advanced prostate cancer? Well, these are men who have much more aggressive metastatic form of the disease. These are either men who, at the time that they were initially diagnosed with prostate cancer, already had metastatic prostate cancer. So that's about 10% of all prostate cancer patients in the United States are diagnosed already with metastatic disease. Also, a large number of men actually initially looked like they had localized prostate cancer, but then progressed after therapy. And one of the unique features of prostate cancer is that it may be 5 or 10 or more years between when someone's diagnosed and when they're eventually diagnosed with metastatic prostate cancer. And then finally, we've included men. There's men who initially, and you can see from this figure, who initially respond to the primary form of androgen deprivation therapy for advanced prostate cancer. And then at a certain point, they're no longer responding and they're considered to be what's called castration resistant. So this is the patient population we're thinking about with advanced cancer survivorship. One of the key elements of this study has been to have a very strong network of stakeholders in a governance structure. So as I introduced to you, the executive committee, which works very closely with the Prostate Cancer Clinical Trials Consortium Coordinating Center, as well as we have a committee that includes members from each of the sites in the United States, as well as country leads from each of the countries. And that's really important in terms of identifying solutions for any challenges that arise, to establish sort of the research priority for this study, and other issues as well. And we have a number of really active working groups that have been so essential to the conduct of this study. I'm going to be talking a little bit about the diversity working group in particular, but we also have, as you can see, just a number of other working groups. I'm also going to be talking about another working group, the low and middle income, or LMIC working group, that's been really critical to the study and engaging our partnerships and conducting the study in the Caribbean, Brazil, and in Africa. So here's an overview of the study design. Again, we're seeking to enroll a minimum of 5,000 men. We're collecting a lot of detailed medical and pathology history information. We're collecting a range of different epidemiological factors, as well as information on other medications they're taking, aspirin, statins. How can those kind of medications men take relate to survival and quality of life? I think a really unique feature of our study is our biorepository, and I'll talk about that in a moment. We are collecting blood longitudinally on the men, and we also have consent in place to collect tissue as well. I'll talk a little bit more about our patient-reported outcome measures. These are getting collected and updated regularly. The idea is that this is a patient population whose quality of life may be changing over time as they're starting new therapies, as their disease is progressing. And I'll talk also about a really exciting randomized trial that we're nesting within Ironman that's using the patient-reported outcome measures. There's detailed information on cancer treatments over time. We've sent out physician questionnaires. So these are questionnaires that are going to the physicians of the participants in our study. We want to capture as much information as we can to understand why treatments are changing. And so you can really see this is both an epidemiologic project as well as a very much a clinically oriented project. And then in terms of outcomes, in addition to the patient-reported outcome measures, we're collecting information on serious adverse events, chronic conditions and comorbidities, disease progression, as well as mortality. So our biorepository central is centrally located here at the Harvard Chan School. The head of this is Patty Sewell, who leads up the Population Sciences Core for the Dana-Farber Harvard Cancer Center. So we're collecting bloods at baseline and at each treatment change, or if a man hasn't changed his treatment by the end of the first year, it will be at year 1. And then again, every year after that, or treatment change. We're collecting information, blood, so that we can look at plasma, whole blood, cell-free DNA and buffy code, as well as RNA. And Patty and her team have been incredibly essential in making the biorepository successful in terms of setting best practices. All of these specimens are getting collected at these hundreds of sites all over the world. And so it's been really critical, the operating procedures that she's put together to ensure that these samples, as much as possible, are getting collected, processed, stored, and then ultimately shipped here in a way that protects the integrity of the biospecimens. So in terms of quality of life information, we are collecting this every 3 months. We're asking men to update us on both their outcome measures as well as their experience measures. And we're using a variety of validated questionnaires to collect different aspects of quality of life. And I'm actually going to present some of the preliminary results that we have, particularly from the baseline questionnaire for these men on some of these domains. And then also for the patient experience, we're using a validated set of questions about what the patient's experience is interacting with the healthcare system. All right, so let's dive into some preliminary results. So to date, we have enrolled, actually these numbers are probably a little bit old, but just over 2,000 men in total. The first man was enrolled in July of 2017, and you can see here what the distribution in different countries looks like. We, as I said, just opened up Nigeria. We were incredibly impressed to see how quickly they were able to enroll men onto the study. Thus far, of these men, just over 500 have either died of their disease or currently have sort of unenrolled from the study as they were too ill to continue to participate. But we will be able to follow up for mortality endpoints for those individuals. We've had 2 big challenges to enrollment. I'm going to talk briefly about how the pandemic has impacted enrollment. But another big impact was the general data protection information that was set out by the European Union, which was originally designed to help protect data from European Union citizens from web browsers, et cetera, et cetera. But for those who've been doing research within the European setting have known that this had a huge impact and really delayed enrollment for about 8 to 12 months for many of our European sites, but we're back on track with those. And as I mentioned, we're still pending activation, but we should be opening up in the Caribbean very soon. Here's just some brief characteristics of these men in our study. I present in the first column the overall for the whole study, as well specifically in the United States. At the time of entry, these are somewhat older men. At the age of entry, their median age was 70 overall and 69 in the United States. Their median age at their initial cancer diagnosis, remember some of these men were initially diagnosed with localized cancer and then progressed, was 66 overall and 65 in the United States. I'm presenting information on self-reported race, but that was reported by the participant, looking again overall versus the United States. And I'm going to talk about a little bit our diversity initiative in the United States as well as globally. Currently in the United States, 18% of the participants are self-reported as Black, African, or African American, and overall it's about 9% of the population. I also wanted to highlight in the US, 17% of the men reported that they had served in the military and our US veterans. This is a group of men that we're particularly interested in, given, and this is even before our partnerships with the VA centers. We want to try to understand what advanced prostate cancer looks like in these men and how it compares to men who are not veterans. I wanted to show you what racial diversity looks like across all of the sites in Ironman. Because Nigeria just opens up so recently, these country level data don't include Nigeria. We just haven't had a chance to digest that data. But I think what you can see overall, as I mentioned, as you can see here, 9% of the study overall is Black, African, African-American, African-British, and then currently we have 2% of men who are Asian. Here you can see in the United States, higher proportion or Black. And then some of these countries, Switzerland, for example, has a very low percent of the population that's Black, so very low. But Brazil, we were able to enroll more than 20% of that population is Black. So I think we're doing a reasonably good job, and I'll talk a little bit about our diversity initiatives to ensure as much of a diverse patient population as we can. We had a publication last year in JCO Global Oncology that was led by Raina McKay, talking about our experience in tackling diversity in a prostate cancer clinical trial setting with respect to the Ironman registry. And this working group that you can see here really has been focused primarily on issues within the United States. Our plan is with Ironman is that each country should develop its own working group to identify what does diversity mean to them, what are the key issues of underrepresented groups in those populations, particularly those that are at greater risk of prostate cancer death, and what are the needs that they need to be thinking about in that global setting. So in terms of our diversity group, we've had a lot of impact in terms of site selection, both in the United States, thinking about underserved communities, as well as partnerships. The collaborations that we've formed with the Afro-Caribbean Cancer Consortium, as well as the Cancer of the Prostate Transatlantic Consortium, have been essential partners to recruit with some of the international sites. As I mentioned, we have a low and middle income working group that's tasked specifically to think about participation from our international sites in under-resourced and infrastructure support needs in Brazil and these other countries. We've played a big role in participant recruitment, site engagement, data quality, as well as being flexible in terms of study design. For example, thinking about what is the translation of different questionnaires. So for example, thinking through what is the best practices for making sure that the translations really capture the cultural issues of different languages in different societies. So I just wanted to present this information. Again, I'm presenting this as part of an epidemiology seminar, but I think there's a lot of really exciting clinical information that's going to be gleaned from the study. And I think it's going to be really an important initiative to look at the practice patterns and how they compare in different countries, as well as in different populations. So now just turning to some of the patient-reported outcome measures, these have been really important in thinking through what are the key issues that are impacting men who have advanced prostate cancer. This is looking at the next two slides are looking at sleep quality, which can be a concern for cancer patients, both because of the disease itself, anxiety, as well as some of the treatments can impact quality of life, and particularly sleep quality. And so I'm presenting here on the left, men who have still that hormone-sensitive prostate cancer that's metastasized, or men who's progressed and no longer sensitive to that initial hormonal therapy. These are thought to be the CRPC group, the men who are more aggressive form of that advanced disease. And so if you think about the percent who've reported having difficulty falling asleep, sometimes or most of the time, it's a large proportion of these men, 45% in the hormone sensitive group and almost 50% in the castration resistant group. Also, when we think about another aspect of sleep quality, do you feel rested when you wake up in the morning? Again, 50%, 1 in 2 of these men are reporting, I sometimes never or rarely feel rested in the morning when I first wake up. We are very interested also more broadly what advanced cancer survivors look like in terms of the financial difficulties they may face as a result either of the disease itself impacting work or as a result of the costs associated with their care. And so the specific question at baseline asked, has your physical condition or treatment caused financial difficulties? And this is looking at by country. The first column is looking at the overall study population and then looking across different countries. And this is the percent of men who either reported that they've had a little or quite a bit or a lot of impact of treatment or their disease on financial difficulties. And I think these data we're just digesting now, and we're very concerned to see the high proportion really in the overall study population in the United States, as well as in Brazil. Pain is another important feature in men with advanced prostate cancer, bone pain in particular, since bone is the main site of metastasis. And a significant percent of our men are reporting both that they're experiencing significant pain in the last week, as well as that pain is interfering with their daily activities. And I think what else is concerning when we look at these measures of pain in different racial ethnic groups, that Black men seem to be experiencing greater amounts of pain. So we need to really dive into this and understand, well, why is that? Is it because of the treatments? Is it their disease state? Is there some biological indicator that would indicate why pain is occurring? And also, are these harbingers of worse outcomes to come? And I'll talk about that in a little bit. But overall, it's really, even with these quality of life detriments that our men are facing, 3/4 of men across different countries report that their overall quality of life is good to excellent. And I think that is, to me, really an amazing thing, that despite the fact that they are experiencing not only the issues that I presented, but many others, that they can still report that they have their quality of life at baseline was excellent to good. It'll be really important to see how this progresses, though, over time as their disease progresses. Just a couple more slides on patient-reported outcome measures. This is looking at changes in social isolation over time. So at baseline, about 10% of the men reported feeling social isolation in the last month. And it seems to be, at least in the men who have more aggressive disease, potentially increasing with increasing disease. This is all this data that I'm presenting here was actually collected prior to the pandemic. We actually have a student who's going to be looking to see, well, how did social isolation during COVID differ in men who have advanced prostate cancer? And then another piece of data presenting here is looking at declines of cognitive function. There's some evidence to suggest that the types of hormonal therapies that men receive for advanced prostate cancer may impact cognitive function. And so what you can see here is about 1/3 of men in this group reported some issue with cognitive function based on a subjective scale. Okay, finally, as I'm going to wrap up with some lessons learned along the way. I think I presented this already, but in terms of what we've learned specifically about diversity and the challenges and opportunities for increasing diversity in the population, I think some of the things that we've additionally learned is the real importance in diverse stakeholders, importance of outreach and inclusion in identifying populations who are underrepresented in general. And I think, in clinical trials in particular, often you're trying to enroll very quickly, ensure that you have very high quality data, which is our goal as well. But those are often at the large cancer centers. And so if you're only going to focus on the cancer center experience, you're going to miss reaching out to these underrepresented populations. It's also important to think about, as a result, that each of these centers are going to have different research infrastructure abilities. And also, the only way that this kind of study is going to be successful is identifying a study champion at each site who's committed to the Ironman mission. And something that we've been able to realize that is, it doesn't only have to be the lead clinician or the lead investigator, but the role of clinical research coordinators in really championing Ironman in different underrepresented settings has been really, really important to facilitate successful enrollment and study activation. Communication has also been really essential, as you can imagine. With a global study, this can really be challenging given time zone differences. So what we have done is to hold sort of the same meeting on 3 different days in a row in different time zones, so that we can ensure that we can maximize the number of people who are able to kind of participate. We have a lot of ways in which we provide feedback, regular interactions with sites, study investigators, patient advocates. This is so essential to really understand the unique needs of each group and really ensure that there's open communication, so that people who are part of this project can help tell us what are the barriers and come up with some really innovative solutions. Globally, as I mentioned, a lot of our diversity initiative has been focused on the US, but we've been working with our partners to really understand what is it around the globe that is, or what are the underrepresented groups that are important to engage in. I think the other lessons that we have learned, and this is new to me, collaborating in lower resource settings, the importance to understand the historical context of research going on, and what has happened in the research setting, and who are the key stakeholders. And then finally, we have an initiative currently for the men who are enrolled in our African and Caribbean sites. They don't have available these next generation therapies for advanced prostate cancer. So their clinical and treatment landscape is going to be very, very different than that in, say, North America or Europe. Well, part of one major initiative, and Emily Rengsock, who I mentioned earlier, is going to be playing a lead role in this, is to figure out a way that we can engage our pharmaceutical partners and provide therapy for the men in our study, with a longer term goal to be able to provide more partnerships to provide cancer therapy for men with advanced prostate cancer in settings where it's much, much more challenging. Finally, to wrap up, lessons learned with COVID. As with other studies, we've had a big impact on enrollment in our study, as well as site activation. Interestingly, though, what you can see in this site is that although all the sites really had a dramatic decline from, say, January, February through to May of 2020, while the US sites have really not enrolled very many individuals, the international sites have been enrolling. And so this has been very interesting to us. And I think we've been following some of the best practices that have been laid out by the Clinical Trials Transformative Initiative about how to conduct studies in the context of the COVID-19 pandemic. This is particularly important for prostate cancer patients who share a number of risk factors for COVID-19 severity, being a man, being older, having a metastatic disease, as well as our minority populations. And we're trying to capture within our physician questionnaires why men might have changed therapies? Was it related to the pandemic? And we're also collecting information on development of clinically significant adverse events and mortality related to COVID. And then finally, we were able to really leverage and adapt our study. So for example, instead of consenting individuals in person, doing e-consent processes, being able to remotely monitor sites' progress, and also the collection of the patient-reported outcome measures using EPROMs has really allowed us to protect participants while also help mitigate any risks to make sure the study integrity is intact. Finally, I just wanted to show one example in which ways we're thinking about using Ironman to nest other studies. So there was a trial that was done suggesting that in individuals on chemotherapy, if you can identify when a individual is and this was not in prostate cancer, this was in breast and colorectal cancer, when individuals seem to be declining with respect to fatigue or pain or other aspects of their patient-reported outcomes, and then intervene, that actually could have a longer health effect on survival. So we're nesting within the Ironman registry and enrolling and randomize 300 men. We're actually randomizing sites. They'll either get sort of their usual care, or if they report on, actually instead of every 3 months, we're going to do monthly surveys on 10 domains of quality of life. If there's any worsening in their symptoms, they'll either get some self-management content on, depending on how worse their symptoms are, or if their symptoms are even more severe or category, the clinical team will be notified with the idea that either the self-management or involvement of the clinical team may be able to help counteract the detriment in quality of life, with a longer term goal of improving quality of life for these men, reducing the risk of significant adverse events, and improving overall quality of life. So I'd like to just wrap up, and there's many, many more people who've been involved in this project and its success than I could possibly present, but this is really an incredible team